Hi everyone, I'm Dr. Dhanraj and today with me is Dr. Stephen Cohen. Dr. Cohen is a plastic surgeon practicing in San Diego, California. He is a master in plastic surgery, especially facial aesthetic surgery, and he has also been a craniofacial surgeon. So now we are going to interview him today about the evolution of facial fat grafting especially and aesthetic facial surgery in general. So sir, how has your career, and welcome.
Thank you very much. It's nice to meet you and nice to have you here.
Thank you. So sir, how has your career evolved? So you've been and you've done so many different things. Cardiac surgery was a part of it. So
yeah, I think because as a kid we had some tragedy in the family. I thought to myself, there's only going to be one life and you don't know when it's going to be over.
Right.
And I pursue things with passion that stimulate my interest. And I think early on for a lot of us, we looked at, when I was training at the pinnacle of medicine, especially surgery, we thought, oh, heart surgery. And so that was my career trajectory. And I was very fortunate to get into the National Institute of Health. Their cardiac surgery branch at the time was kind of a training ground for future chairmen of heart surgery programs all over the US. It was really quite remarkable. Unfortunately, I saw a TV program on craniofacial surgery in my last year. So I was all set. I did very well at NIH. And I just remember turning to my wife and going, I'm going to do this instead. I really didn't know anything about it. I didn't know any plastic surgeons. I did my general surgery at Columbia. And at the time, we didn't like the plastic surgeons because they were dilettantes. You couldn't get them to come in for emergencies. They seemed to be scared of body cavities. And none of that stuff was really much of a problem from my point of view. But once I saw craniofacial surgery, I was like completely blown away by the possibilities of altering, young people's appearance and making them really go from monsters to normal. And it was the most remarkable thing I saw. So I literally changed my career.
Like you did your whole cardiac surgery almost in the last year, and then
I did. I finished my fellowship, and then I went and I trained in plastic surgery. I was fortunate. The heart surgeons that I knew liked me enough to write me nice letters, although they wrote like, we don't know why he's doing this, but he's really good. And I was very, very lucky to be accepted to University of Pennsylvania for my training. I trained with Peter Randall, who was a master cleft surgeon, Linton Whitaker in craniofacial surgery, and probably my favorite, a Italian-American guy, Donato La Rosa, who is deceased now, was just one of the most magnificent surgeons to watch. It was like listening to, a Bocelli song, watching him operate. It was beautiful. And from there, I went to UCLA. I did craniofacial surgery with Henry Kawamoto, who probably was the Paul Tessier's favorite disciple and probably his most talented surgeon. And I was fortunate to take a job as head of craniofacial surgery at the University of Michigan. Mm-hmm. And then I got recruited to Atlanta to an amazing job with the fellow who actually invented the tram breast reconstruction, a guy named Carl Hartranft. And we were in practice together with a group that we built up and eventually sold, and then I moved out to San Diego and took over the Children's Hospital and really started my aesthetic career. So I've been doing aesthetics about the last 20 years, and in 2018 I stopped my craniofacial practice, and now, I'm a beautician.
Totally. Beautician is one way some people would call it. But
yeah, I joke because the general surgeons, the heart surgeons, definitely refer to it as a beautician. Now they're pretty jealous because they go, you have a good lifestyle, you're not dealing with insurance companies, you must be smart, you must have predicted the future. And it's like, not really, just following my heart along.
So throughout the aesthetic surgery, the plastic aesthetic surgery that you have been in the past 20 years, how have you seen it evolve?
Well, the techniques have become so much more refined. I mean, what we're able to do in the deep neck for contouring and removing glands and muscles, what we're able to do to the underlying bone structure if need be, and the deeper planes of the face have, I think, revolutionized our facial aesthetic surgery. I think that's a very important component. So technically, better and better training and better understanding of anatomy have led very far away from just the skin-only facelift. That's one. Two, I think science has progressed, and especially in the arena of fat grafting, which is an area I've focused a lot on. When I first started practicing, fat graft was just beginning to happen with a few people, and then actually it kind of fell out of favor. A handful of people continued doing the Cohen technique, and Sid Coleman, plastic surgeon in New York, really established a standardized technique. Now, I was brought up to question standards, and so no offense to Sid, because I think what he did made it very plausible for everyone to do in a simple way. But what it didn't do is it didn't really address what I think fat needs to do, which is replace the lost volumes that are occurring in deep and superficial fat compartments. So once we began to understand the anatomy, and once we actually realized the multitude of cells that were in fat and available potentially for different therapeutic uses, the whole field, in my opinion, changed. And because I live in San Diego, San Diego is the #2 biotech cluster in the US.
Okay.
I'm exposed very frequently to new companies.
To all these companies were.
Exactly.
I think even the first paper which came about the adipose-derived stem cells was in 2001. So I think that's the same time when you also started getting into.
And purely because of that paper, what happened was Mark Hedrick, Adam Katz, folks at UCLA and at Pittsburgh published a paper on recognition of these multi-potential cells or stem cells, mesenchymal stem cells in fat.
Right.
And they formed a little company called Stem Source. Well, I was involved in a company here called Macropore, which we ultimately took public, sold to Medtronics, and we bought Stem Source, and I was one of the medical advisors involved with that. And so very early on, we started to think about what are the things that could be done. So we did small clinical trials on a series of 8 patients where we did cell-assisted lipo transfer. And the results were, I have to say, underwhelming at the time. It's a little bit like when you first started doing fillers and Botox. You had to convince yourself what you were seeing. You had to train your eye to see. And you can't see what you've never seen. So it's like giving somebody a microscope and suddenly you go, look what's crawling on the table. Suddenly, as you start to train your eye, you begin to see what is actually occurring in the skin. And I had one patient come in 6 years later with still corrected wrinkling. And it was very interesting to start to think, how do we harness these cells? Interestingly, at first we were doing it to patients who were heart attack victims. So we were doing studies in Europe and in the US where we were injecting these cells into a coronary artery within 24 hours after a heart attack to stabilize the at-risk muscle, to provide a better blood supply, to reduce the frequency of arrhythmias, and to reduce the frequency of heart failure. And these were anecdotally successful, but very, very difficult trials to do on a large scale.
Right.
And this has been probably the bane of the problem for cell therapy, is that it's very hard to do an easy randomized study. You do a study on fillers, this filler is used in this fold, saline is in that fold.
Right.
It's very easy because the filler is stable and the variability, yes, it's in the patient, but it's kind of really more related to the filler.
Yeah.
With regenerative medicine, when we do these studies, we're not controlling for what the chromosomes of the cells that we're using are like. So if your cells are already senescent and mine are young, I'm going to do better. And without that control, these studies have not really shown wow kinds of results. And it's unfortunate because this will be a wow science in the future.
And I think it's also difficult to measure the changes that are actually happening because of
it can be difficult also.
The technology that's there today to measure all these changes is not as advanced or as easily accessible to get those changes documented.
Yes, I agree.
I'd say that.
But I think we're coming now to a point where, at least in my own mind, what I started to do was back up a little bit and say, look, people don't even understand cell therapy yet. So let's go back to conventional fat grafting.
Mm-hmm.
If you look at a patient and how they age, from my craniofacial days, we know that they lay down a functional matrix which causes the bone to grow and supports the skin. And that happens for the first 22 years of life. And then we begin to decay. So I thought nuclear decay is like starting mass, ending mass, and the rate of decay is how quickly you get there. So could you apply this logic in human aging, especially tissue aging? So what I thought was, if we are able to replace the decayed volume, and this is a more legitimate replacement where you improve the blood supply, you actually provide new cells to the patient, are we going to change these curves of decay and the rate of decay? And I think this is what we're starting to see. And in studies that we've published now that are prospective, using an anatomic and regenerative approach. So not just it looks pretty like a filler, but this is fat that is put in the medial deep fat compartment, in the medial SOOF, in the lateral SOOF, in the deep malar regions, in the retrofrontalis fat pads. Once you start to look and see what's decaying and you replace that in patients who are less than 55 years of age, 2 years later you actually saw an 80% improvement in facial volume. In other words, they were actually like having trophic effects. So you're changing these decay curves from a rapid decay to either a complete reversal temporarily and then again a slow decay, but you're beginning to modify how tissue ages. And to me, that's the exciting part about regenerative medicine for dermatology, plastic surgery, and other areas of medicine we haven't even tapped.
Yeah, I think that's a very common question in doctors and in patients. I mean, that's one of the most common questions that we get, that how does it compare with fillers, or like what is the difference between fillers and fat when you use it for volume changes. So what you said right now, that this ability to regenerate the tissues and create more than what was actually implanted,
Yes.
that is, I think, the key to how it's working.
And there have been some very good studies now done. There was one by Charles Dessau and Gino Rigatti out of Brazil and Italy, where they looked at the histology in patients having facelifts, and they treated them with cell-enriched fat on one side and not on the other about 3 months before the facelift. So when they removed the skin in the course of the facelift, they looked under the microscope. And under the microscope, on the treated side, there was actual reversal of age changes in elastin and collagen, and then a huge amount of new capillary formation or new blood supply.
And that's within just 3 months.
And that was within 3 months.
Exactly.
When we start to think about every study in fat grafting, whether it's cell-assisted or it's simple fat grafting, every study has shown increasing capillary density or increasing blood supply. Virtually every study has shown reduction in inflammation and some degree of repair. So right now, let's take an example. You have a knee injury and the cartilage disintegrates a little bit and it's painful. Well, we treat that with a steroid injection. That thins the cartilage, causes more cartilage loss, but makes the pain go away. If we treat that with cell therapy, okay, maybe we don't get a grand slam, maybe we get a 20% improvement, but that's 20% from zero. So as we start to combine certain treatments and address the specific tissues and cells that are involved, I think we're going to see that the efficacy of these approaches increases. So there's some very unique things that are happening with this.
Right. So in this, what are the most, like if you were to say the three most important advantages of using lipotransfer, like we were just discussing. So what is it that excites you most about fat?
So I think one is it legitimately replaces what we've lost. And in plastic surgery, we always try to replace like tissue with like tissue because you get the best results. That's number one. Number two, it's natural, so it's generally harmless to the body. And three, because you have these regenerative effects, you're actually improving the tissue that you're placing in it. So if you open up a coronary heart artery after a heart attack and provide blood supply back to the heart, it functions better. If you provide blood supply to the skin, it functions better. And its function is to protect us as a barrier. And as we begin to learn what happens with aging and know that as the skin breaks down, the bacteria and other pathogens that can get into the bloodstream through an enormous surface area play an important role in our gradual deterioration. So things that we can do not only make us look better, but probably keep us healthier.
Right. So with these advantages, what are the conflictingly opposite to it, what are the disadvantages that you would see?
And that's a great question. So the disadvantages are...
Or the challenges, if I may.
Or the challenges. One challenge is, a patient wants an immediate effect. They want to go out to dinner 2 nights later with their lips and their face looking bam. So for aesthetic outcomes that require kind of short-term recovery, fillers are a great choice. For patients that understand that this is different than a filler, this is more of a foundational approach. It doesn't exclude using fillers. This has a lot of advantages, but you have to accept the reality that we are variable. So you go to high school reunions, some people you look at them, they look amazing. Other people you go, I hope I don't look that age. Well, some people age more rapidly and their tissue ages more rapidly. If we're using their tissue now, they may not have the same, great effects. They'll still have an effect, maybe not as powerful as somebody already who's kind of a slow ager, if you will, and has healthier tissue.
Correct. So that is one of the...
So I think the variability can put some people off. But there's no real, there are 2 biologic fillers and they stimulate the tissue and they do certain good things while they're in and then they disappear. Whereas this is actually replacing tissue that's been lost to some extent. So I think those have been the main limitations, and also that people still think that fat grafting is the Sid Coleman technique. That's a technique that injects everywhere for aesthetics. And I think the variability in that has shown that at 2 years, maybe there's a 20 to 30% effect still there. Whereas we're starting to show at 2 years an almost 80% improvement in facial volume is present.
So when you say 80% improvement or when you say 30% improvement, you're comparing, what is the 100% there? Is that the normal tissue that the patient had maybe 10 years back, 20 years back?
No, you're comparing it to their baseline preoperative evaluation. So you can make a volume assessment of the midface before treatment, and then at a month, 3 months, 6 months, 9 months, a year, etc., up to 2 years. And so what you're doing is comparing it to that preoperative baseline. So initially they get a 60% improvement over their preoperative level.
Correct.
And then it goes down to about 30%, say between 6 to 9 months, because the fat dies, but the stem cells replace the dead fat, and also the blood supply improves, so the native tissue becomes hardier, more robust. So it declines, and then coming up around 9 months, it starts to increase. So when I say 80% improvement at 2 years, it's 80% improved facial volume from the pre-injection status.
And would you put that 80% thing to say 100% for a filler procedure? So when we are comparing fat and fillers for just the volume, and you're saying 30% or 80% with the fat. So in that case,
I think
then
you could.
fillers
What you would do, you would say, not necessarily. You would say that the filler produced a certain percentage improvement, and then that improvement would gradually decline.
Of course.
And you know,
Of course.
fillers also have a gradual decline, so
Yes.
they're not stable and then disappear. You know, poof.
That is
They're gradually going away also.
correct.
So
So maybe in the immediate 2 or 3 months, it may be 100%, and then gradually.
Yeah. And you know, the reality is we don't know what is in fat that's doing this. It could be that for the regenerative effects, maybe it's exosomes, which are really more blood-borne kinds of cell messengers. So
Right.
maybe we don't need the fat for regeneration. Maybe
I was just going to come to that part. So, even in plastic surgeons, even in dermatologists and people who are practicing regenerative medicine, the clarity about the concept of what microfat is, what nanofat is, what stromal vascular fraction is. Now there's also stromal vascular hybrid SVF, so the matrix part of it. So how would you put all of this in a very simplified language, and where do you see the role for each one of them?
so. For replacement, you know, fat grafting and or fillers are going to give you volume replacement. For regeneration, it's a menu. So typically more growth factors, more stem cells, more exosomes, higher populations of these regenerative cells give better, more effective results. So it's a menu, and at the bottom of the menu, in my opinion, is PRP, platelet-rich plasma. And then nanofat, because nanofat, depending on how you prepare it, is more of a cell-depleted stromal vascular fraction. Stromal vascular fraction being everything but the fat cells. So that's depleted in nanofat. And then you start to get to stromal vascular fraction that's mechanically made. That is about 40% of what you can get when you use an enzyme. So now when you then use a hybrid stromal vascular fraction, you're basically taking those 40% of cells that fall to the bottom in a centrifuge and you can collect, and you're adding those with the Buffy code, and now you're getting the same equivalency you get with an enzyme.
Okay.
So that menu would also be a menu of expense, but a menu of effectiveness. So that's how I look at the present landscape. Now, exosomes are going to be an important and critical aspect to this. We don't know exactly their relative strengths. My guess is they're going to be pretty substantial. They may be the active ingredient in fat, but they're probably only going to be one component, the paracrine effects, you know, the cell-to-cell messenger. So, you know, still likely it's going to be combinations of exosomes and hybrid SVF to get the most effective, you know, repair or reduction in inflammation, etc.
So from what you just said, there are 2 points that I want to come to. I'm going to come to the cost part later, the expense part that you said.
Yeah.
But with better understanding of the stromal vascular fraction.
Excuse me.
Oh, God bless. So with better understanding of the stromal vascular fraction matrix and the stromal vascular fraction per se, do you really see a role for nanofat? When we're now understanding, maybe not 100% sure that the disrupted oil that we get, which we discard, doesn't play any role. That's the understanding right now.
Yeah.
So in that scenario, do you see any role for nanofat, or are you like, no, I'm just going to, like, SVF matrix is going to be the future?
You know, I think the future will be the SVS matrix, but I think it takes a while for physicians to understand what is happening. So, whereas you have a broad knowledge, I have a broad knowledge, most physicians, PRP, nanofat, and then that's where everything stops. So I think it's important to help physicians understand the field by training them in those basics, and as they begin to acquire those skills, adding on the others. And then I think it'll evolve. But basically, the rate limiting step becomes cost. So if stromal vascular fraction matrix is more expensive, some patients will not opt for it. There'll be other patients where you say, look, you have scleroderma, we need to throw everything, including the kitchen sink. You have to do this. Otherwise, yes, you'll see some effect, but you're not going to see the same effect.
Correct. I think that, I mean, of this whole discussion, this is one of the important parts. The the way it's going to change, and then the cost part comes into it.
Yeah.
How do you see the expenses going ahead? Are they going to keep on increasing? Are they going to get reduced over time? And how does it look out for the patients?
So I think part of the problem is industry has a requirement, and when industry gets involved, one of the requirements is can they sell capital equipment. So the expenses for hospitals and larger clinics may increase.
Right.
On the other hand, this can be very simple, and there are many devices now, for instance, like our little nanocube.
Yes.
They're $100, so it's very inexpensive to do. And even to produce stromal vascular matrix, our Lipo cube device is $600. So, you start to really not find that the expenses a huge impact.
Good.
And as these things become more available, like anything, supply and demand. The
true.
cost of goods goes down and the goods proliferate.
Correct. I think that's an important part. So, as we come to the ending part of it, in the next 5 years or in the next 10 years, where do you see this whole regenerative thing going with the things that are currently being done? And what do you think is going to come new?
Okay. Well, I think a few things are going to happen in the next 5 years with regenerative medicine. One, I think that we're going to find that for many people, exosomes replace PRP. And because you'll be able to get them from the blood.
Right.
And because of that, that'll be a very simple solution for dermatologists that are not like you, where they're not comfortable harvesting fat, but they're comfortable doing fillers, but they need a regenerative product to inject. So now they'll have a regenerative product. So I think that's one. Two, I think that the cosmetic industry is poised to have a seismic disruption. Right now, the only real active ingredient in most over-the-counter cosmetics is retinol. Well, we're involved in a think tank out of the UK, and we've come up with a solution that's probably 40% more powerful than retinol and has no real FDA barriers. It can be used in a cosmetic tomorrow. I mean, they're obviously manufacturing this and that. So I think as these kinds of concepts come out, and these are exosome-based concepts, but with a different tweak, I think that is going to change the way cosmetics become, and they'll be more effective. And then I think that in terms of wound healing and treatment of a variety of different diseases that we really haven't tested these things against, like psoriasis and things that really don't have cures, we may see some very remarkable improvements using these regenerative approaches. So I think those are the main things in the next 5 years. I guess I would add one more fourth thing, that anti-aging could also become very popular. So for instance, it's not inconceivable that you can use a plant exosome or an animal exosome that are no problems to incorporate into a pill. And those can be used for anti-aging because there's a concept called parabiosis, where if you join a young mouse's circulation to an old mouse's circulation, the old mouse's organs all get young because of circulating exosomes. So if we're able to take young exosomes and we're able to ingest those, we may actually be able to have a huge anti-aging effect. So I think this is a potentially seismic change in the way we practice medicine and the way we approach, natural aging.
Thank you so much for those tips. As a parting way or the parting words, in the regenerative world, there's also a lot of hype that's going on about regeneration. So people are touting stem cells, injectable stem cells, intravenous stem cells for anything that they may think of. And then there's some science behind it, and there's also some hype behind it. So for the patients or for the doctors, what your advice would be as to how to look at these therapies?
It's a tricky.
People are touting it even for, say, if you're tired, get IV stem cell therapy.
It's tricky because it depends on the source, the reliability of the scientists that are doing it. I mean, if you have reliable scientists that just happen to be unable to practice, say, in the United States or in India or another country because of regulations, but they're able to go to the Caribbean and practice.
Yeah.
And these are legitimate, well-recognized scientists. Sometimes people have to be innovators and they have to be willing to take those risks to move something along. But how do you ferret that group out from the marketers that really don't care at all other than lining their pockets? That is a very tricky thing. I would say most of the legitimate researchers are doing more legitimate marketing, more high-end marketing. You're not kind of like, $9.99, come and get it. But it's a little hard to ferret that out. It would be ideal, obviously, if these were studies that people were entering into so that we would have the ability to understand what's happening to the chromosome. Are we really producing anti-aging effects? Because if we're not, there's no point in doing these things. And I wake up every once in a while with a kind of a frightening thought, or am I going to be looked at, and is this field going to be looked at like, the old people who were traveling around in, wagon wheels and selling, a bunch of crap and saying
the magic potion.
The magic potion's going to help you with everything from a brain tumor to, being able to pee in the morning.
Yes.
So, but I don't think so. I think this is going to be more like the world of immunotherapy. I mean, it's taken 30 years for immunotherapy to become mainstream, and now people with stage 4 lung cancer are living with their diseases.
And then when it came, most of the oncosurgeons were not even believing in it.
Totally. And the results were very modest at first. And then as people began to realize certain things seemed to be working, and combinations of things, bam, it started to really take off.
That's true.
There's a plastic surgeon in Italy who I think he's brilliant. Probably some people are a little uncomfortable with him because he is quite brilliant, a guy named Michel Zocchi. And Michel has been doing combination therapy in the knees now and getting extraordinary results. And it's not just because he's doing stromal vascular fraction, he's doing that with certain vitamins and other components. Again, as we learn what these cells need to become more youthful or to be repaired, we're going to be able to see more, I think, substantial advances.
Correct. And the Lipo Cube device, so I missed talking about that, so I want to talk about that a bit.
Sure.
So how did you come to think of and then design and get it into the market, the whole Lipo Cube device, and for the SVF? What is the thought process behind it? And so for the young doctors out there, how do they go about getting a scientific idea into a viable option which actually helps doctors give science
Sure.
to patients?
A lot of that is just stumbling and kind of luckiness. So for me, I was working with a group of Turkish, Israeli, Swiss surgeons and researchers, and they had developed a system to get SVF mechanically, and they were getting yields of about 40% of what an enzyme did. And I had been working with other companies on developing little tools for nanofat, and I went with one company, and that company kind of took my ideas and made them their own. And then I worked with another company who kind of did the same thing, and then I just became a little frustrated, and because these were good friends of mine, I said, is it feasible to develop a cube similar to what you have, but a cube that would allow us to make more of a cell-optimized nanofat? And we literally came up with this concept in a couple of weeks. We were on the market within months.
Wow.
COVID obviously created a stumbling block. But the hard part is not the concept and even building a prototype. One, it's protecting that, so you want to have good non-disclosure agreements, patent pending, provisional patents, and then you go talk to companies that may be strategic partners for distribution and commercialization, because it's very hard if you're being a full-time doctor to be a full-time business guy. You need to find people who have that skill set. We don't have it. I mean, if you want to give up practice and that's what you want to do, you'll develop it. But other than that, you got to find the people that have the right contacts, and that will then distribute and sell devices.
Correct.
And even then, it's not easy, because devices, there's always going to be 3 or 4 companies that have very similar devices. So that commercialization becomes very dependent on who's got the best sales force, who's got the most penetration.
Correct. Who's
So
got the more experience.
a whole different business mindset.
Correct. And then after a few years, that technology is going to go, so you have to keep on innovating.
Exactly, like Leonardo da Vinci said, art is never really finished.
Yes.
And these concepts are never finished because you're always trying to move them to the next level. And you don't want to get hooked into the fact that, and again, I think it's easy to do, because if you get a name associated with something, it's like, oh my God, it's my invention and it's disappearing and it's obsolete. You have to think to yourself, that's the whole point of all this. You want to make your own inventions obsolete. You want to think, what's the next thing? So if exosomes replace the need for nanofat, to me, that's brilliant. I want to be involved in that, because to me, we want to continue to move things forward, not stable because of my ego needs, even though I have those, but for the greater good, right?
Thank you so much, Dr. Cohen.
You're welcome.
And just because you mentioned Leonardo da Vinci, I want to just briefly talk for 2 minutes about the paintings behind us.
Yeah, these are kind of
So Dr. Cohen is a very passionate artist, and all the paintings that you see here and his whole clinic is full of all the great pieces of art that he has done. So just a word about how it has evolved as a passion for you, and how do you see it?
My wife bought me some paints in 1984. Maybe she said to keep busy. I don't know. But the reality is, when I first started drawing, I was drawing like more realistic faces, and I was like, wow, I did one. I didn't want to put the hat on because the face was so surprisingly good that I was afraid I'd ruin the thing with the hat. I actually still have that at home. And then I had an artist friend, and she just said, I said, should I take lessons? She said, no, just keep painting. And so what I did was develop kind of my own kind of technique of putting a wash down and looking for faces or figures, because I love faces. And so it's like responding to a Rorschach test. Mm-hmm. And as I do that, it allows my emotions to come out by accident, because I don't restrict myself. I don't say, oh, that's good, or that's painterly, or that. So these become like almost like childlike expressions. It's like if you've retained that portion of your soul, it comes out very easily. And so I've just kept painting, and it's more of a meditative thing, and people like them. So anyway, and if they don't, too bad, it's my office.
I love them.
Thank you.
Difficult to understand when you first look at them initially, but
They're
I think eventually it grows onto you.
Well, and it's not meant, contemporary art's not necessarily meant to understand as it is to respond. If it creates a response, like I have a friend, a Brazilian plastic surgeon, and she came up to do a course, and she loved the work, and I said, would you mind writing a little blurb, because I'm going to publish a little coffee table book. And she just wrote, they're like little poems, they're just they're very nice, they're very light, they create a nice feeling. That's really...
Exactly, that's all. It's just a feeling, you can't express it.
Exactly, that's all I'm looking to do.
Thank you so much for all the time, and thank you for hosting me here.
It's been a pleasure.
Thank you.
I hope to visit you in your country one day.
Definitely.
Now that I have my outfit, I'm ready to go.
Yeah, definitely we'll do that. I would love to have you there, and sometime in the near future
hopefully
we're going
we'll
to have
be able
you,
to do that.
so that many doctors also back in India benefit from all the experience that they've had.
It will be fun.
Yeah. Thank you.
You're very welcome.